She had a cupped lips. When she smiled, she showed a narrow upper arch with palatally inclined upper canines and crowding of the upper and lower teeth. She had convex profile due to protrusive maxilla and retrusive mandible. One was extruded and brocaine. So this is the digital models of the patient. It showed class 2 half unit buccal relationship on the right, increased overjet, 1/6 was missing, increased overbite at the frontal view, class 2 half unit buccal relationship on the left. Low incisors were extremely crowded. 4/6 was distally lingually rotated. The low incisors were over-erupted, causing deep bites and palatal indentation. 1/1 was displaced from the arch with crowding. The panoramic radiograph showed missing all wisdom teeth and 1/6. There were angular and horizontal bone loss. Sectioning the upper model in the middle of 1/1 at the sagittal plane showed increased overjet and overbite. Furthermore, if the red circle indicated the center of resistance, it showed that intrusion of 1/1 at the bracket level would protract the tooth during alignment. Therefore, straight wire mechanics was contraindicated as it would protract upper incisors and resorb labial bone. The visual treatment objective or VTO was set at the lateral set for 1/1 with the blue line indicates the pre-treatment position and the red line indicates the planted position. 1/1 was planned to have 7 mm of retraction to correct the overjet and 2 mm of intrusion to level the tooth with 2/1. Space analysis and anchorage planning was done by the occlusogram software with instruction to extract tooth fall. It indicated a moderate anchorage need on closing space at 1/6 and 2/4 regions. On the lower arch, the low incisors were planned for proconation of 2 mm and intrusion of 2 mm. I instructed the software to extract free tooth to relieve crowding. For 4/6, which was outlined in yellow, it was planned to derotate distal buccally with the center of rotation at its mesial contact point, which was indicated as the black dotted circle. An orthodontic engineering software called Dental Movement Analyzer was used to calculate the line of force to intrude 1/1 to the planted position. The movement was done by a 3-piece intrusion and retraction arch, which will be shown very soon. This is the ideal virtual setup based on the occlusogram software, with the pre-treatment tooth position shown in yellow and objective tooth position shown in white color. The setup showed clearly that after the extraction of 3 tooth, sequential intrusion of the low incisors and canines were required, and they presented with different level of over-eruption. First, we need to intrude 3/1, 4/2, and 4/1. Next, intrude 3/3, 3/1, and 4/3. And finally, intrude 3/3. These are the pre-treatment intraoral photos. Treatment progress. On the upper arch, beta titanium 1725 T-loops were used to retract canines. Ligature wire were used to tip incisor distal during canine retraction to open space for 1/1. On the lower arch, beta titanium 1725 3-piece intrusion and retraction arch was used. This time, the white arrow depicted a line of action that was slightly labeled to the center of resistance of the low incisors, which was represented by the red cross. This line of action would result in intrusion and procanation of the lower incisors. A passive stainless steel lingual arch and segments of stainless steel 1925 labial arch wire were used to split the lower premolars and first molars together to reinforce anchorage. As the treatment proceeds on the upper arch, we can see that sufficient space was generated for the leveling and alignment of the 1-1. Beta titanium 1725 three-piece intrusion retraction arch was used to intrude and retract 1-1. And the line of action that was produced followed the mechanical plan created using the dental movement analyzer. On the lower arch, sequential intrusion of lower 3 to 3 proceeded. An overlaid beta titanium 1725 box loop was used to intrude 3-1. It produced an intrusion force only on 3-1 without any moments to tip the tooth mesial or distal. At the same time, a beta titanium 01H arch wire was used to hold the position of 4-1 and 4-2 with the posterior teeth. It reduced the tendency for 4-1 and 4-2 to extrude and tip distally. Also, a beta titanium 1725 arch wire connected the two crosshead mini screws, which were inserted at 3-3 and 4-3 distal buccal regions. It served as an anchor to intrude 3-3 and 4-3 with palm chains. On the low arch, there was another crosshead mini screw which was used to fix the position of 3-6 with a passive stainless steel 1925 arch wire. It eliminated the clinical side effect which happened at 3-6 when the passive stainless steel lingual arch was replaced with a beta titanium 036 lingual arch. The active lingual arch was used to derotate and expand 4-6. At this appointment, her oral hygiene deteriorated, especially around the 3-piece intrusion and retraction arch, and she was asked to return to her periodontist earlier. Therefore, I did not activate her orthodontic appliance on the upper arch. We can see that the intrusion and retraction of 1-1 was in progress. On the lower arch, 3-1 and 4-3 were level. 4-6 was derotated and was fixed by another crosshead mini screw at 4-6 region. This was the mini screw which fixed 4-6. Let's go back to the low occlusal view. The beta titanium 036 lingual arch, which was fixed by the mini screw at 3-6 and 4-6 region, was used as an anchor to intrude 3-3 on the lingual side with a power chain. And on the labial side, a power chain was used to intrude 3-3 at the same time with the mini screw anchorage. As the 3-3 was being intruded by both the lingual and labial forces, it should be intruded body. The patient returned to my clinic with the oral hygiene improved. On the upper arch, the intrusion and retraction of 1-1 was completed. On the lower arch, the intrusion of low incisors and canines were completed. At this time, a beta titanium 1725 arch wire was used for alignment. Now, on the upper arch, the bracket on 1-1 was reborn to the normal position. A stainless steel 1925 arch wire was inserted. And on the upper occlusal view, we can see that lingual buttons were born slightly above the CEJ level, and the power chains were applied to close space. So why did I need the linker buttons? For periodontally compromised tooth, as I've mentioned, the center of resistance, which are indicated by the red circles, are at the apical level. When we apply force to close space at the bracket level, there is a high tendency for the teeth to rotate towards each other. The rotation will cause binding and notching of the arch wire to the bracket, which creates a lot of friction during space closure. To reduce the friction, the linker buttons can be bonded on the palatal side of the incisors so that the force can be applied closer to the center of resistance and the tendency of rotation reduces. In this example, the friction can be reduced to 1/3 only. After the upper space was closed, upper incisors in canine were cemented with a cobalt-chromium cast beams with extensions to direct the space closure force at the level of the center of resistance of the teeth, which was deeper towards the palate. It was again to reduce friction. Reciprocal anchorage was used for space closure as planned. These are the photos taken after debonding. In fact, the treatment was terminated prematurely due to periodontal flare. The cobalt-chromium screens was retained and was used as permanent fixed retainer after the extensions were sectioned. We can see that the space closure was incomplete and there were caries which were restored at 3, 6, and 4, 6 nasal regions. Luckily, the periodontal condition was stabilized after debonding, and these were the photos taken at the 1-year retention. So before and after treatment, panoramic radiographs. 1-3 became non-vital, and the root canal therapy was done. There were a significant amount of shortening of roots at the low incisors, particularly due to the root resorption, particularly due to the 3D projection of the trochanter low incisors, which appear to look shorter at the radiograph, which was a 2D image. There was also root resorption of upper incisors. Intrafrontal view, upper and lower teeth were aligned. One was intruded. There were gingival recession at 3-1 and 4-1 after treatment. However, the recession at 1-1 and 2-1 were improved as they were brought deeper inside the alveolar process due to intrusion and retraction. Upper arch was aligned with shortening of dental arch after partial space closure. The cobalt-chromium cast beam was kept as fixed retainer. Lower arch was aligned and 4-6 was derotated distal buckling as planned. Fixed retainer was formed on the lower anterior region. Overjet and overbite were reduced. Buccal occlusion was class 1 on the right. Canine class 1 and molar class 2 half units on the left. Lip competency was improved, rest incisor exposure was reduced. People can see the well-aligned low teeth when she smiled. So her smile was improved. The poor condition of upper incisors were improved. Roots of upper incisors were brought in the middle of the alveolar process. The lower incisor were protruded slightly. Her face and her smile were also improved at the 3/4 view. So Rachel was 26 years old when treatment was started. This lady had a very severe car accident when she was young. It caused scars on her lips, limited range of hand movements. She had competent lips and normal incisor exposure at rest and during smile. Rest smile up, upper dental midline coincide with her facial midline. She had maxillary protrusion, retrognathic mandible, and convex profile. This is her digital models. She had class 2 half unit buccal relationship on the right. She had lower midline shifted to the right, increased overbite. The long absence of the posterior teeth of the upper left allowed the lower teeth to erupt to fill the space. There was no interocclusal clearance for tooth replacement. 3.5 and 3.1 were displaced buccally from the arch due to crowding. Lower incisors were over-erupted and were contacting the palate behind the upper incisors. She lost 2.4 and 2.5 due to the car accident. Also, she had impacted 2.6 and 2.7, which might be caused by primary failure of eruption. If we look at the frontal view of lower teeth, we can see a progressive over-eruption of teeth from 4.3 to 3.7, which required sequential intrusion. This is her lateral set, which shows skeletal class 2 pattern with maxillary dental alveolar protrusion, retrognathic mandible, and compensatory proclination of lower incisors. This is the panoramic radiograph, which shows the impaction of the wisdom teeth 2.6 and 2.7. The white line was constructed to show the vertical position of the posterior teeth. It showed the progressive over-eruption of teeth from 4.3 to 3.7. I plan to extract 2.8 and 3.6, but to keep 3.7 for a period of time to help align 3.4 and 3.5 in the transverse plane. After the completion of the alignment of 3.4 and 3.5, the extraction of 3.7 would be done. Therefore, the anchorage which was provided by 3.7 was free, and this is called the free anchorage. Following this, I plan to upright 3.8 when it had erupted. I plan to extrude 2.6 and intrude the lower incisors canine 3.4 and 3.5. The false vectors which produce the desirable tooth movement were acting in the same direction, and therefore I could not move these teeth by reciprocal anchorage. Furthermore, there was a risk of causing ankylosis of 2.6 in response to the orthodontic force if the cause of impaction was a primary failure of eruption. Because of that, I should not attempt to erupt 2.6 at the expense of the anchorage of the other upper teeth. In conclusion, skeletal anchorage had to be used. This was how she looked after the extraction. And these are the clinical photos before treatment. And 2 mini screws were inserted at 2.4 and 2.5 region and were brought to the beta titanium second 25 cantilever with composite for extruding 2.6. So this is the radiograph taken on the day of starting the orthodontic eruption. The tooth was erupted successfully in 6 months. In order to create interocclusal space for the eruption of 2.6, a silver syringe with anterior bite plates was cemented on the upper arch. On the lower arch, a passive lingual arch was cemented to fix the arch width, and the lower teeth were bonded for alignment with light-eye wires. After 6 months, when 2.6 was erupted successfully, on the lower arch, we can see that the arch form was improved, and this was the time when 3.7 was extracted, as there were significant interocclusal interference between 2.6 and 3.7. And the leveling of lower 3 to 3 was done with the help of the mini screw, and the intrusion of 3-4 and 3-5 continued after the extraction of 3-7. So on the upper arch, we can see the whole clinical crown of 2-6, and the silver spleen was replaced with a removable plate, so that the patient could get rid of this immediately when 3-7 was extracted. When the upper teeth were aligned, minuscule was inserted at 1/6 mesobuccal region between the upper incisors. Also, an extension was born to the minuscules which were used to erupt 2/6. So they serve to provide anchorage to retract upper incisors and control the vertical position of the incisors. At the same time, intrusion of 3-4 and 3-5 was still in progress. And on the lower causal view, we can see that 3-8 erupted spontaneously after the extraction of 3-7. This was the time when I bond 3-8 and insert a beta titanium 1725 cantilever to upright the tube. We can see the cantilever from the frontal view, which was covered by a plastic tube to protect the cheek mucosa. And because the cantilever was quite long, the light force applied to extrude 3-8 and intrude the arch wire between 3-2 and 3-3 could produce a large moment, resulting in distal tipping of the 3-8. Now you can see the overjet and overbite were corrected, and the interocclusal space was open for tooth replacement. The case was deboned, and 2-4 and 2-5 implant were in place. Sectional orthodontic treatment was done to dislodge 2-6 to make extra space for the crown of 2-5, with the anchorage of the implant supported crown at 2-4. And 2-5 crown was in place. 2-4, 2-5, 2-6 were brought together to stabilize 2-6, as patient was pregnant and the replacement of 3-6 was postponed. Finally, 3-6 implant supported crown was in place. Panoramic radiograph after treatment. 1, 2, and 2-3 require endodontic treatment. 2-6 was brought into the occlusion, and 2-7 erupted together with 2-6, even though I did not apply any orthodontic force to it. If you look closer, it seems like 2-6 and 2-7 were connecting each other with the cementum. Therefore, I didn't attempt to extrude 2-7 separately, as I worried that it might over-erupt 2-6. The CBCT showed the implant was replaced 2-4, and the implant was replaced 2-5. The panoramic radiograph showed the implant supported crown at 3-6. The lateral self after treatment, the protrusion was improved. The cephalometric superimposition, lower incisors were proclined, upper incisors were retracted, 2-6 was extruded about 10 millimeters. Before and after treatment, intraoral frontal view, overbite was reduced, and 3-4 and 3-5 were intruded, 2-6 was extruded, interocclusal space was open. Upper arch was round off, 2-6 was fully erupted, 2-7 was partially erupted but not in occlusion with the lower teeth. The lower arch form was improved. The smile arc was improved. Orthodontic traction of 2/6 brought bone around 2/5, which is an example of implant size development by orthodontic tooth movement. 3/4 and 3/5 were intruded. 3/8 was upright. Stacy was 37 years old. And the frontal view, the upper midline was shifted to the right. The gingival was asymmetrical when she smiled, with the left side showing more than the right side. This was partly due to the facial asymmetry, with the chin deviated to the right, and partly due to her upper lip elevator muscles, which were more active on the left side when she smiled. When she said Emma, there was increased upper incisor exposure at rest, and her lower incisors were crowded. 1/1 was discolored, and upper incisors were tilted to the right side. She had intumbent lips and flat chin, convex profile. There were maxillary dental alveolar protrusion when we look at her at the 3/4 view. On the lateral set, we can see an increased vertical distance between the palatal plane and the occlusal plane, which indicated maxillary dental alveolar hyperplasia in vertical dimension, or total vertical maxillary excess. The blue lines indicates the pretreatment teeth and jaw position. The yellow lines indicate the plantar position, which was visual treatment objectives. On the sagittal view, I plan to retract and intrude the upper incisors and intrude the upper molars. This was to improve the maxillary protrusion and total vertical maxillary excess, which would improve the lip competency. The intrusion of upper dentition would cause counterclockwise rotation of the mandible, which would improve the lip competency and chin prominence at the same time. On the panoramic radiograph, there were missing wisdom teeth, 1/4 and 3/6. There were multiple restorations and root fillings. I had referred her for endodontic retreatment of 4/6 and restoration of 1/5. 1/3 and 4/5 require extensive amount of ridge resorption, which would take extra time and consume more anchorage. Digital models. Class 2 half unipolar and class 1 canine relationship on the right. Upper and lower midline were shifted to the right. Full unit class 2 canine on the left. Unclassified molar relationship due to missing 3/6. 4/6 was missingly drifted. 3/1 and 4/1 were lingually displaced. 3/1 and 4/1 were over-erupted. 1/2 was palatally displaced and rotated mesial palatally. 1/6 was mesially drifted. I plan to extract 2/4 and 4/4, correct the midlines, retract and intrude the upper incisors. And based on the virtual ideal setup, which was done by the occlusogram software, on the upper arch, we need to dislice 1/6 and 1/7, 2 mm and retract 235 mm. We need skeletal anchorage on these movements. This makes space for the alignment of 1/5, retraction of upper incisors and correction of the upper midline. On the lower arch, I plan to keep the AP position of 3/1 and 4/1 and align the arch along them. We need to close space at 3/6 and 4/4 regions with skeletal anchorage. This makes space for the alignment of lower incisors and correction of lower midlines. These are the intraoral photos. The treatment was started with retraction of 2-3 separately with minuscule anchorage. At the same time, 3-3, 3-4, 3-5, and 4-3 were being retracted, so that also with minuscule anchorage. 3-2 and 4-2 were moving along the arch wire as they were tied by the ligature wire to 3-3 and 3-4 during retraction. And if you look carefully, I used a cross-head minuscule which connected to 3-6 with a passive arch wire. It served as an anchor to upright the root of 4-5 into the extraction space of 4-4 with the use of beta titanium 036 lingual arch. Next, 1-6 and 1-7 were dislodged with indirect skeletal anchorage. It means that an opening coil was used to push the 1-6 distal against 1-3, but the mesial movement of 1-3 was prevented by the steel ligature which connected to the minuscule at the 1-3 distal buccal regions. At the same time, pouching was used to correct upper midline by moving the incisors to the left when 2-3 was being retracted. This was the time when the root of 4-5 was uprighted, and there were enough space for the alignment of 3-1 and 4-1. This realization of 1-6 and 1-7 continued. Retraction of 2-3 was in progress. When there were enough space for the alignment of 1-5, a single steel 014 cantilever spring was inserted at 1-3 to move its root mesial, as the CBCT 3D rendering showed that the roots of 1-5 and 1-3 were overlapping with each other. Right now, I was intruding the whole maxillary dentition and the lower molars to improve the total vertical maxillary access. At the same time, an opening coil was used to push the lower incisors mesial against the premolars to correct the lower midline. At the frontal view, the lower midline was off to the left. Now the lower midline coincides with the upper midline. On the left side, the space was closed between 3-3 and 3-4. And on the right side, this was the time when the root of 1-3 was fully uprighted and was separated from the root of 1-5 mesial distally. So on the left, a crosshead minuscule was used to fix the position of 3-3 with passive wire and composite, so that the space could be closed from behind with pouchings without changing the lower midline. And the upper occlusal view, I inserted a beta titanium cantilever aiming to bring the root apex of 1-3 back into the bone by palatal root movement. Since this cantilever ran diagonally across the palate, it had a long movement arm that enables it to effectively bring 1-3 palatally with a large movement, while keeping the magnitude of the intrusion and extrusion forces low. This was the patient before the bonding, and this was the patient 1 month after the bonding. From the CBCT, we could see that the root of 1-3 had brought inside the bone buccolingually and was separated from the root of 1-5 mesial distally. The post-treatment retrocept and the sacrometric superior position, the facial height was reduced, upper incisors were retracted and intruded, . panoramic radiograph before and after treatment. The roots of 1, 3, and 4, 5 were uprighted. 3, 7 were brought mesial. RCT was done at 1, 3. PCT image before and after mesial and palatal root movement of 1, 3. And at the frontal view, the teeth were aligned, but unfortunately, the upper midline correction was incomplete. It was slightly to the right side. Upper arch was aligned. Upper first molar were aligned to the same level in the sagittal plane of space. Lower teeth were aligned. 3, 7 was mesialized. 3, 2, 4, 2, 3, 3, and 4, 3 were distalized. Class 1 canine and molar relationship on the right. And class 2 half unit canine and full unit class 2 molar on the left. Incisal exposure was reduced. Lip competency was improved. The lower incisors were aligned. And gingival exposure at smile was reduced. But I did not attempt to correct the canting as it matched with her deviated chin, which made her smile look more natural. So labial mental flow was improved because the chin was rotated forward slightly. Maxillary protrusion was improved. It was the time for the restorative dentist to take over. So here we can see the bleaching was done. And multiple restorations, which included crowns and veneers, were done at 1.6, 1.3 to 2.5, also at 4.6. Gingival surgery was done at 1.2 and 2.2 also to improve the pain aesthetics. So this was the patient after bleaching. And the restorative dentist helped me to improve the upper midline and the gingival levels. So this is the brief introduction of what he has done. Digital smile design, or DSD, confirmed the facial asymmetry, which was mentioned earlier. The intercanine and interpupil lines were found canted around 3 degrees to the true horizontal plane at the natural head posture. After discussing with the patient, the restorative dentist decided to accept the cant as it matched well with the chin deviation to the right. Therefore, he tilted the photo in a counterclockwise direction to level the intercanine and interpupillary line to the floor and proceeded to the plan. According to the DSD, the size of the upper central incisors was in correct width and length proportion, yet the midline was 1 millimeter shifted to the right side. Based on the ideal template, it also demonstrated the need of gingival recontouring, especially at 1, 2, and 2, 2. The treatment objectives were: first, improvement of dental midline; second, improvement of white and pink aesthetics. Therefore, internal bleaching of 1-1 and full mouth bleaching, nasal gingival recontouring, crowns and veneers were planned. First, the teeth were scanned so that the digital setup could be done according to the DSD plan. Next, the resin model was printed out based on the digital wax-up. A silicone index was made from the resin model printed out to transfer the plan design to the patient. This was the result of the bleaching. After that, a proton mock-up was bonded to show the patient the planned result, and it served as a guide for laser gingivectomy at 1, 2, and 2, 2. This was the immediate result of the gingival surgery, and composite was formed after this at the interproximal surface to mold the interdental papilla. Next, tooth preparation for crowns and veneers were done with minimal invasive approach with the help of the proton mock-up and the silicone index. The silicone index was used to check the amount of tooth reduction, and tooth preparation was completed for all ceramic crowns of endodontically treated 13, 11, 24, and veneers on 12, 21, 22, and 23. The shade matching was done digitally with the photo taken with this template. Provisional restorations were cemented for another check of the smile aesthetics. Tooth form and speech with the patient, and her feedback was reverted to the technician to confirm the design of the final product. The patient was happy with the provisional restorations. The first try-in before cementation. Patient requested an upper central incisor to be more prominent, as the edge of the upper central incisor is located exactly at the wet-dry border of the lower lip, which was the best position. The restorative dentist had decided to change the inclination of the lateral incisors instead, so that the central incisors could look more stand out. This was the final form and inclination of the prosthesis. The lateral incisors were slightly retrograde. Before and after the restorative work, and we have a patient very happy after treatment. This is the end of the case presentation. So what are the points which I want to deliver through these cases? First, many of these adult cases have compromised periodontal condition. For Natalie, her treatment was contraindicated to straight wire mechanics. What was the reason for that? If we compare an extruded tooth which has normal periodontal support with a tooth which has reduced periodontal support, the center of resistance moves equally when the periodontal support reduces. Therefore, if a light tie wire is engaged into the bracket for alignment, there is a higher tendency for the tooth with reduced periodontal support to protrude, which will in turn produce a loss of spacing and loss of labial bone. Because of that, we need to design a custom appliance which can deliver the correct forces to the tooth at the correct position. For Natalie, engineering software was needed to calculate the correct line of action to retract and intrude 1-1. This was the custom appliance which was designed to deliver the forces calculated by the software. For the same reason, during space posture, the teeth with reduced bone support will produce a lot of friction. Therefore, on the left, lingual buttons were born close to the gingival level. On the right, the colpocomium splint with extensions and transpalatal arch, which when dipped into the palatal bulbs, were used to produce the line of force closer to the center of resistance to reduce friction during space posture. Sequential tooth movement was very important in Natalie and Rachel's case, as their lower teeth were over-erupted at different levels. Therefore, they had to be arranged in different groups and intrude in a specific order. Otherwise, the tooth movement would take longer time and cause more anchorage loss. Given the severity of tooth displacement, skeletal anchorage was often needed. Mini screws were placed at different positions to provide anchorage to move teeth according to the planned sequence. This was the most efficient way to deal with complex tooth movement. That is why you could see multiple mini screws which were inserted at different positions. In Natalie's case, at this time point, I was intruding 3-1, 3-3, and 4-3, and derotating 4-6 at the same time with 3 mini screws. In Rachel's case, more minuscules was used to extrude 2/6, intrude and decant no incisors in canines, and 3/4 and 3/5 at the same time. For Stacy, I uprighted the root of 4/5 and retracted lower second incisors, the canines premolars at the same time using the screw anchorage. Next, I had these lines 1/6 and 1/7 to create space for the alignment of 1/5. Only after this, I could move the root of 1/3 mesial to open space for the root to move palatal. This was to prevent the roots of 1/5 and 1/3 from hitting each other during alignment. Therefore, the root movement of 1/3 requires staging. First, mesial root movement and then palatal root movement. Adjunctive tooth movement is often advocated for adults with compromised dentition in orthodontic literatures. It often involves treatment with limited objectives to assist tooth replacement or improve aesthetics. A good example is the treatment I provided for Rachel after her comprehensive orthodontic treatment. I bond the brackets to the implant supported crown at 2/4 and to 2/6. A stainless steel RY was fully engaged into the bracket slot passively, and an opening coil was used to create extra space. Only 2 months were used to open space for the replacement of 2/5. However, for most of the adult cases which I encountered, orthodontic full mouth reconstruction were required to produce good function and stability. If reconstruction is needed, there were more factors to consider. Since I don't have time to cover all the factors, I would like to boil down my treatment planning philosophy into one sentence. That is, plan from the face to the alveolar bone. Taking Stacy as an example, I needed to set how much the upper incisors must be retracted and intruded to ideal position and test in the lateral set to see if the roots were still inside the bone when the teeth were in the plantar position. This treatment planning procedure is called Visual Treatment Objectives or VTO. We need to consider an important fact that alveolar process is one of the limits of the orthodontic tooth movement. Next, I had to decide the arch form and plan the tooth movement on the occlusal bracket. Again, I had to make sure that the roots were still inside the bone after the teeth were aligned. In case the biological limit is violated, either we have to change the treatment objectives or orthodontic surgery has to be considered. Most importantly, the patient and the members of the dental team must be involved during the shared decision-making process. However, does careful and meticulous planning eliminate all the complications? You had already seen a lot of problems which happened in my cases. For Stacy, root canal therapy was needed for 1/3 even though I was able to bring the roots back into the bone. And for Natalie, 1/3 required root canal therapy in the end, and there was a periodontal flare-up of the upper incisors and root resorption of the lower incisors. In her case, in order to bring the upper and lower incisors closer to camouflage the underlying skeletal problem, it carried high risk. The reasons were, firstly, when teeth moved over longer distance, there was a high risk of roots being moved beyond the alveolar process. Secondly, even if the roots stayed within the bone, orthodontic tooth movement could lead to root resorption, especially when they need to travel a long distance. And thirdly, challenging movements require more time, increasing the possibility of periodontal and endodontic flare-ups. Finally, difficult cases need complicated mechanics, and often appliances are difficult to clean. For Natalie, her oil hygiene level was not consistent throughout the treatment, and eventually we found wood carries around the passive wire, which connected the meniscus to the orthodontic band of forceps. With all the possible complications which could happen despite careful planning, does it mean that we should refrain from providing reconstruction treatment to adults with compromised dentition? Do the benefits of the treatment outweigh the risk? For Rachel, who has suffered from a car accident, her occlusion caused pain and discomfort, especially on the left side, with over-eruptive traumatizing gingiva constantly. She had a couple of teeth extracted, multiple meniscus were used, and eventually root canal therapy was done on 1, 2, and 2, 3. Although 2, 6, and 2, 7 were brought into the arch, nobody knows how long she can keep the teeth. Despite all the sacrifice and uncertainty she faced, we were able to reconstruct her bite, and she can now eat normally without pain. For Natalie, we're not sure how long she can keep her incisors. However, what we know for sure is, even if she may suffer from tooth loss in the future, tooth replacement will be much easier and the quality of the prosthesis will be better, as we have reconstructed her bite properly, which can cope challenges in the future. Taking all these benefits into consideration, they will still go for treatment if they are allowed to choose again. But most importantly, they were well informed with the risk before treatment started. Finally, as these cases involve general dentists, endodontists, orthodontists, periodontists, restorative dentists, who should take the lead during the treatment? I think there's no definite answer, and it depends on the personality of individual members within the team and the team dynamics. However, the most important thing is someone in the team should take the lead and coordinate the discussion and treatment for the patient. It would be the best if the team can hold regular joint consultations and study clubs to share information and develop the relationship together in a progressive way. So if you are interested to know more about the details of Natalie's case and the use of a video and occlusogram for treatment planning, we can refer to the book chapter which was written by me and another 2 co-authors. Finally, I would like to sincerely thank all the colleagues who have collaborated with me while treating these patients. Thank you very much for your attention.